Well, hello everybody, welcome and thanks for coming. There's a whole bunch of people signed up and there's some excellent questions, so we'll see how many of them are able to log on. What I'm gonna do is I'll start with the people that are here and the questions that you guys asked, and I'll just identify you by name, and then that way we can have a little bit more of a one-on-one conversation within the group, and you can ask follow-up questions or make sure that I answered the question appropriately. So I'll just go down the list here. So the first one on this list is Mr. Nori Hamad. Nori?
Yes, hi, doctor. Thank you for
Hey, how
your
are
time.
you? So
Doing well. Have
your question was related to double outlet right ventricle transposition VSD and pulmonary stenosis. And you said the ventricles are normal size, but the VSD is inlet. What's a good weight for biventricular repair? What's the best surgical option? So that's a good question. And double outlet right ventricle is a very complex one in that double outlet right ventricle can mean a whole bunch of different things. And there's a variety of different surgical options available based on the location, frankly, of the ventricular septal defect. If the VSD is inlet, that means it's far away from both valves, the pulmonary valve and the aortic valve. It's a lot more straightforward if the VSD is close to either the aortic valve or the pulmonary valve. And there's two, no, I don't want to call them easier, but two more accepted biventricular operations that are performed for those situations where the VSD is close to one of those valves. When the VSD is farther away, like it is with an inlet VSD, it's a lot harder to know which operation to do. So the options are one, to do what's called an arterial switch operation, which is to direct the VSD to what will become the aortic valve, which what used to be the pulmonary valve, and do what's called an arterial switch, where you transpose the great blood vessels. Another one's called a Rastelli operation, where you tunnel the left ventricle to the aorta through the VSD. And the third option, frankly, is the univentricular repair. So you don't do a biventricular repair, but you do a Deland and a Fontan. And intuitively, you would think that the last option, the single ventricle repair, is the worst of the three. But actually, if you look at the data for a lot of double outlet ventricle kids, it's not the worst of the three. As I've said before, a good single ventricle operation is much, much better than a borderline biventricular repair. I think it also depends on which type of biventricular repair you're talking about, because if you're talking about an arterial switch operation, that can oftentimes be a one and done operation, and kids oftentimes don't need any other surgical intervention. If you're talking about a Rastelli operation, which means tunneling the VSD or tunneling the left ventricle through the VSD to the aortic valve, then you have to put in what's called a conduit, which is artificial, between the right ventricle and the lungs, and that needs to be reoperated on at regular intervals throughout life. So it really depends on the location of the VSD in relationship to the valves. You asked what's a good weight for biventricular repair. Well, I never really went based on weight. It's really when the kid needs it. So it depends, again, what type of biventricular repair you're doing. If you're doing an arterial switch operation, you can do it earlier. If you have to do a Rastelli operation where you're putting in a conduit, then you like to wait a little bit longer so you can get a larger conduit size in, so it lengthens the interval between operation number 1 and operation number 2. So that's a lot of stuff to throw at you. I don't know if that makes sense, or if I answered your question appropriately, or if you have follow-up questions.
No, thank you. That was very clear. One thing that was confusing, we've had a few different post-birth echoes, and on some of the reports, it says inlet VSD. On some of them, it says subpulmonic, like VSD with inlet extensions. I don't know if that's the same thing or.
Yeah, no, it's not the same thing at all. But the other big issue with your child is pulmonary stenosis, right? So pulmonary stenosis oftentimes negates the ability to do an arterial switch operation because the pulmonary valve, which would become the aortic valve, is not good. So you can't turn it into the aortic valve. So then you have to do the Rastelli operation. But I don't know how much pulmonary stenosis your child has. First of all, how old's the kid?
Right now, she's 4 months.
What are her oxygen saturations?
So she had a central shunt at 3 days.
Oh, she did. Okay.
Yeah.
So if she had a central shunt, that means the pulmonary stenosis is pretty severe enough that she needed extra blood flow to the lungs via the shunt. So that means she wouldn't be a candidate for an arterial switch. So she's either a Rastelli candidate, and a subpulmonary VSD is not as good for that, but again, it all depends on the location. And certainly an inlet VSD is also not as good for that, but again, it depends on the location. So when they say subpulmonary extending to inlet, that's different than inlet. So you really have to know where the VSD is in relationship to the valves. And nowadays, I mean, I don't know if they've talked about this. Where are you from?
In Los Angeles, California.
Yeah, so Children's LA?
Yeah, with Dr. Von Starnes.
Oh yeah, well, I mean, Dr. Starnes is an awesome surgeon, so I'm sure they've talked about this. If they haven't, you can ask them. But oftentimes nowadays you can do 3D CT scans, reconstructions, and so you can actually print out a model of the heart, and it gives a surgeon a much better idea because you can actually look at the model rather than just looking at 2D images. And I've done that for a number of kids with difficult location VSDs to actually determine where the VSD is. You can pick up the heart in your hand, the plastic or whatever, and rotate it around and try to figure out what operation you do. And that makes it sometimes much easier to discern preoperatively what you would do. But I mean, you're in good hands with Dr. Starn, so I'm sure I'll make the right decision.
Thank you very much. Yeah, he also mentioned the aortic root translocation as a possibility.
Yeah, right. So that's a bigger operation. It's called the Nikoto operation, the aortic root translocation, which it's less commonly done, although more commonly done probably in the last decade than before that. It's a huge operation. It's bigger than the two that I mentioned. It also involves putting a conduit in. So anytime you put a conduit in, that's a step that needs to be worried about, in the sense that your kid will need additional operations as they outgrow the conduit.
Thank you. That's very helpful.
Well, you're quite welcome. Thanks for joining in from LA. The next one on the list is Mr. Rao, Sagar Rao.
Hi, yeah, thank you for that. Yep.
Yeah, how are you? So your questions are: what are the long-term complications of the Fontan repair of a hypoplastic right ventricle with tricuspid atresia? And does hypoplastic right ventricle need the 3-step single ventricle palliative surgical options, or does the Glenn at 6 months and the Fontan at 4 years suffice? Okay, so I'll start with question number 2. Well, first of all, I'll tell you that tricuspid atresia tends to be one of the better variants of single ventricles. So there's a zillion different types of single ventricles. If God told you, listen, your kid's going to have a single ventricle, which one do you want it to be? You would pick tricuspid atresia. And part of the reason for that is that you have a dominant left ventricle in tricuspid atresia. Some kids have hypoplastic left ventricles, and they're left with a dominant right ventricle. The dominant right ventricle was never meant to pump blood to the body for ever and ever, but the left ventricle is meant to pump blood to the body. So it's, if you're going to be left, if you're going to remain with one ventricle, it's better to have it be a left ventricle. Now, as far as 2 steps versus 3, That depends. It all depends on the kid, and it depends on how much pulmonary blood flow there is at the beginning. So some kids have not enough pulmonary blood flow, meaning there's not enough blood getting to their lungs, and then they need a first step operation. Some kids have too much blood flow going to the lungs at the beginning, and they also need a first step operation. It's a different operation, but they need a first step operation. In some kids, like Goldilocks, have just the right amount of blood getting to the lungs when they're born, and those kids can often be managed until they're 4, 5, 6 months of age, at which point they're suitable for a Glenn operation, so they can skip step 1 entirely and go to a Glenn and then a Fontan. So is your child, where is your child in this?
So she's not born yet. My wife is, well, we're expecting her to be born the end of this month. We had this diagnosis prenatally, and throughout the ultrasound appointments that we had, we were told about all of these options, the surgical options, but towards the past about 1 month or so, we've been told that we may not need the first surgery and it might just be the second surgery.
Yeah.
And I didn't know whether that was a good thing or a bad thing. So I just thought I'd ask that.
Yeah, no, it's a good thing. Which means that there's probably some anatomic evidence that your baby is going to have what's called balanced pulmonary blood flow. So that can either mean that there's some degree of narrowing of the pulmonary artery, and a ventricular septal defect also present. There could be narrowing of the VSD. There's a variety of ways in which pulmonary blood flow can be limited in kids with tricuspid atresia. And there's some kids with tricuspid atresia who have too much limitation of pulmonary blood flow, and then they need additional pulmonary blood flow. But again, if they're telling you that there's a chance that your baby might skip step 1, it's because there's some evidence anatomically that there's some self-regulation of pulmonary blood flow. And now sometimes what happens is the kid has too much pulmonary blood flow at the beginning, but it looks like whatever is limiting pulmonary blood flow will get worse, which in effect is better in the sense that, they'll regulate the pulmonary blood flow on their own. You just need to give them time. Sometimes it gets worse too fast, and then you need step 1, but that step 1 comes a little bit later than usual. Usually step 1 comes in the first few days of life, but sometimes step 1 can come like up until a month of age or even later than that. The thing to remember is that it's really not usually permissible to do a Glenn before around 4 months of age. It depends on some other factors. I mean, you can do it a little bit earlier than that, but that's when the pressure in the lungs drops enough that a Glenn is an acceptable form of palliation. So, it all depends on what the baby's oxygen saturations are. That's the cheap way to measure all of this when the baby's born. If the oxygen saturations are acceptable, then no first step is necessary.
Gotcha. Thank you.
You're welcome. Where are you from?
I'm from Ontario, Canada, and we've been seeing at Sick Kids and Mount Sinai.
Yeah. So again, Sick Kids is a great place, and I'm sure they'll give you sage advice.
Thank you.
Okay, next we'll go on to Angela Maffin. How are you?
Hi, Dr. Gandhi. Good. How are you doing?
Good. How's Avery?
She's doing well right now. She's doing quite well.
To fill everybody else in, and hopefully I remember all of this right, but Avery was born with a complex form of what's called tetralogy. It's not the basic tetralogy, though. She had a hole in between her heart, in between the 2 pumping chambers, in between the 2 ventricles, of ventricular septal defects, and severely limited blood flow to the lungs. In addition, she had these extra things called collaterals, which are extra blood vessels that are floating around in the ether to give blood flow to the lungs. And initially her lung arteries were really, really small. So I think the first operation I did was to put in a conduit. That was it, just between the right ventricle and the lung arteries to get the lung arteries to grow. And they did. And then there was another operation somewhere along the line to replace that conduit and make it bigger, and then to what's called unifocalize one of these collaterals, which is to bring into play the extra blood vessels by sewing them into the main lung circulation. And then finally, I don't remember when I did this last operation, was a complete repair, which is to close the hole in between the two pumping chambers of the heart, and then to give her a full-sized conduit between the right ventricle and the pulmonary arteries. And the concern I had with that operation, and the concern that I think has existed since that operation, is that the lung arteries were way better, but they weren't normal, and that would result in a high pressure inside the right ventricle by closing the ventricular septal defect the whole way. That's the ultimate goal, is to close the VSD, because it makes the oxygen saturations normal or close to normal. But the problem is, if the capacity of the lung blood vessels isn't good enough, then the pressure on the right side of the heart, in the right ventricle specifically, will stay high. So that's what was observed early on. And in your question, you said that she's currently taking tadalafil, which means that tadalafil is like sildenafil, which is a pulmonary vasodilator. It drops the blood pressure in the lungs, which means that the blood pressure in the lungs is still high when the right ventricle is still under high pressure. So the question was, which is a better situation over time: prolonged high pressure in the right ventricle and the conduit, or having an open VSD with lower SATs? She currently takes tadalafil. She's doing okay. Low physical stamina, but that's nothing new. SATs around 80 at rest. So has the pressure in the right ventricle changed at all?
No, it's pretty much stayed the same. And her last surgery was in October of 2020.
Oh, so it's been quite a while. It's been 4 years.
Yep, she's 8 years old now.
And so why is this bringing up, or have they brought up opening the VSD up again? Is that why you're asking?
I guess I'm asking just as your opinion, as you know, it's your beautiful work on her heart, and so I just wanted to touch base.
I mean, I think it depends on how her right ventricle is coping.
Okay, so
coping.
Her right ventricle is coping quite well. So we've been getting the echo every 6 months or so, and it seems to be staying the same. We've, however, had 2 episodes over a couple of years where, after she's been sick and coughing for a few weeks from just a virus, she's ended up coughing up blood. And that's been obviously a very big concern. We've been admitted. It's been a whole investigation, and haven't really pinpointed where that blood was coming from. It sort of magically healed up both times, and we were so grateful, but it was very, very scary. So it's been a pretty scary, bumpy road for her, up and down. She was also diagnosed.
Coughing up blood is obviously very scary. The problem with that too is that it can be from so many different things.
That's right.
Blood.
Yeah.
But certainly pulmonary hypertension, which is what we're talking about, high blood pressure in the lungs, can cause that.
Mm-hmm.
So I don't know what kind of investigation she had when she coughed up blood, but certainly if that was something that was recurrent and happens a bunch of times, then you have to give more consideration to opening the VSD. See, the thing is, when you open the VSD, you're not going to drop the pressure on the right side. It's going to stay the same, because the VSD is going to equilibrate the pressure between the left side and the right side. So it doesn't actually drop any pressure. The one thing that it does is it allows the right ventricle to unload a little bit. So if the right ventricle is not struggling, like if it's working well, then there's really no reason to open the VSD. If the right ventricle shows any evidence that it's struggling, it's not functioning well, she has evidence of what's called right heart failure, then we're in a completely different scenario, and then you have to think about opening the VSD.
Right.
But some people have the misconception that, okay, opening the VSD is going to fix the pulmonary hypertension. No, it's not. The pulmonary hypertension is going to stay there. It's just a matter of giving the right ventricle a little bit of breathing room, so to speak. So I would only do it certainly at this stage, 4 years down the road. I mean, if she's made it past the first 4 years, then she stood the test of time. But I would only do it at this stage if the right ventricle was worsening, and it might, like, to be honest with you. And if it does, then I think you have to give consideration to doing that. And it will, as you say, drop her oxygen saturations further, although they're already not normal. So I must have left an ASD open, right?
Yes.
Yeah.
Yep.
So I mean, that's another good thing in the scenario, is that since her ASD is open, there is a way for the right ventricle to chill out a little bit. Like, it's not as direct as opening the VSD, but it's still there. So in theory, leaving the ASD open is a significantly protective factor. So it would be a lot different if her ASD was closed.
Okay. So that's very reassuring to hear you say that, stood the test of time, and obviously I know things can happen, but I really appreciate hearing that from you and touching base with you on this, because
Sure.
yeah.
Did she get did she get a bronchoscopy when she coughed up blood?
She did not. She did not, because it stopped. By the time we kind of got settled after emergency and everything, it had stopped, right? She wasn't continuing, so they didn't want to do anything too invasive, I guess.
Was it with an infection?
She didn't have an infection at the time, but she had an infection 2-3 weeks prior and had been coughing quite heavily for 2 to 3 weeks, both times it happened.
Did she have COVID?
She has had COVID, but it wasn't at the time that she had tested positive. No.
So,
no.
I mean, that's the other thing. Like, all the coughing can, irritate something too. And it can be, I don't want to say as benign as that, but in the scheme of things that cause one to cough up blood, irritation of the airways from coughing is the best thing to have, right? Like, what you don't want is a blood vessel somewhere that bursts, that's causing blood to make you cough up blood. What you do want, if you coughed up blood, is, okay, well, my trachea or the airways, the bronchi that lead to the lungs or something, is something scratched in there, and that resulted in blood. That's why I asked if she had a bronchoscopy, because if you have a bronchoscopy and you see something, then it makes it a little bit easier to figure out what to do next.
Okay.
Oftentimes you don't see anything, but if you see something, it helps.
Right. Okay. Yeah, we were going to investigate with ENT a little bit and see if it could be something that was in her throat or her nose as well, because they really weren't sure if it could have been something that came from up higher. But yeah, I was very, very scary both times, not knowing if it was going to stop and if, further intervention was going to be needed. So it was pretty scary stuff. But other than that, she's doing all right. So thank you very much. We really appreciate it.
She's come a long way.
She really has. She's a beautiful little girl, and she does dance, and she's, just silly and lovely. And thank you, Dr. Gandhi.
Yeah, you're quite welcome. That's awesome. Okay, so next we'll go to Kati Chincha. So you have a bunch of questions. So her little girl it has an abnormal tricuspid valve and pulmonary valve, and is probably headed toward what's called a 1.5 ventricle operation, where you put in a conduit and leave the atrial septal defect open, a conduit between the right ventricle and the lungs. So your question, conduits in pulmonary atresia, what are they? for a valve replacement, would it be the pulmonary valve plus conduit? When is open heart needed to replace a conduit, and can you have a valve replacement with no conduit? So those are all good questions. So what a conduit is, a conduit's any tube that allows blood to flow. In this scenario, most often the conduit that we use is what's called a homographed conduit. So a homographed conduit is a piece of pulmonary artery with a valve that comes from a cadaver. So somebody that's died and their heart wasn't acceptable for a live heart donation, but we use pieces of people's hearts and use them to fix children's hearts. So we use pieces of tissue, we use aortic valves, we use pulmonary valves. So in this situation, it would be a pulmonary valve with a piece of the pulmonary artery that you can put in someone that doesn't have that. And it's probably the most common type of conduit used in pediatric heart surgery. So to put it in, yes, it's open heart surgery. To replace it, it all depends. So if it's big enough and the patient's suitable, when it comes time to replace it, sometimes nowadays they can put a valve in the cath lab through the existing conduit. That's not a permanent fix, but what it does is it extends time on the conduit. Conduits can last for a year, 5 years, 10 years, 15 years. It all depends on the size of conduit, the child, their metabolic rate, like lots of different things go into how long conduits last, what type of conduit it is. But anyway, so to replace a conduit, to replace it completely, yes, you need another open heart operation. To extend its life, oftentimes you can get by with a cath lab intervention. Can you have a valve replacement with no conduit? Yes, you can. You can have a situation where they put in an artificial valve and then some tissue over top of that valve. I mean, it all depends on the anatomy of the situation. Typically, a conduit's easier, and I think in terms of like longevity between a prosthetic valve and a conduit, it's 6 1, half dozen the other. It's dealer's choice, really. It's what the surgeon wants to do. And the other question is, my daughter's hemoglobin's gone up in a year from 150 to 170. Could that be normal variation, or is it an indication that she needs repair? No, it's not normal variation. That's definitely an increase that's significant. Is it significant enough to warrant heart surgery at this point? As we've discussed in the past, that all depends on all of our other signs and symptoms. It's significant. It's something that can't be ignored. I wouldn't say that 170 is hard and fast cutoff, but it's certainly something you can't ignore. If the hemoglobin level is a sign that she is cyanotic most of the time, shouldn't she have other symptoms like clubbing on her fingers? No, not necessarily, not with her anatomy. Clubbing really occurs when you're deeply cyanotic, and her SATs are generally pretty good, like in the 90s. So you have to have prolonged SATs that are much lower than that, like in the 60s and 70s for a long period of time to develop clubbing. So clubbing is not a good indication of the need for surgical intervention at all. It's more of a late stage finding. We don't really like to see kids with clubbing, especially when they're on a surgical track somewhere. We like to intervene well before that.
Okay. Yeah, like we had our consult just yesterday, and the timeline really like still kind of like the same, kind of in the fall, more likely really like in the spring next year. and we talk about this, right? They may actually like go up and down the stairs, and I know really like when she goes, she has exercise intolerance, so they said they measure really the oxygen saturation, and like she was like going like down into the 60s, even 50s, running and going up the stairs. Normally it's something that probably she doesn't really do. I know really, I've seen her really like when she tries to run or tries to do something, like she gets out of breath, she gets tachycardic, but she like recovers and she paces herself like really well. So probably she's never really under that stress really as she was yesterday when they made the test. But yeah, anyway, like that's where we are really. And like, what would be the complications really of having like the hemoglobin that high? I mean, if I decided not doing it.
Stroke.
Stroke?
Stroke.
No, okay.
That's the main complication of a high hemoglobin is stroke.
Okay. Dr. Gandhi, and with the conduit, I've heard really that sometimes you just put really this pulmonary valve really through a CAT procedure. And I know that Daniela definitely, she needs really open heart because of the ASD. And, but like.
You can't put it in with the cath procedure if you've never had it before.
Oh, okay. But like once she gets this, the next valve could be just the valve?
Yes.
Okay. And that would be like, could be cut, like, I mean, if everything
yes,
is.
But again, that's not a fix. It prolongs the life of an existing conduit. It's not the same as replacing a conduit. It can prolong the life significantly, but that doesn't mean that you're out of the woods as far as future open heart surgery. Once you have a conduit, in a kid, almost inevitably, you're going to need more surgery.
Why does she need the conduit? I mean, why she can't just go straight to the valve replacement without the conduit?
It's the same thing.
It's the same thing.
I mean, like I said, a conduit valve replacement, it achieves the same thing. It's just terminology, which type you use.
Okay. Okay, thank you.
Okay. Let's see. Trying to find other people that are on the list here. Somebody speak up if you're on the call, asked a question and I haven't responded, because I think I responded to everybody.
Dr. Gandhi, there is Mr. Nouri had one question that I'll just post into the chat that maybe you could address as a follow-up.
Okay.
There you go.
Is
Can you see that one?
Is an inlet VSD with outlet extension an indication that a biventricular repair is possible? We've had 3 to 4 echoes and CT scan. Each one has different interpretations for the VSD. TE says subpulmonary, CT says inlet, and the TTE, which is the transthoracic echo, says inlet with outlet extension. It's very confusing. Yes, it's very confusing. And that's why I started my answer to your question by saying double outlet rear ventricle is very confusing. So double outlet rear ventricle can be so many different things based on that location of the VSD. So it can be subpulmonary, it can be subaortic, or it can be neither of the two. It can be inlet, it can be remote. It can be so many different things. So when you have 3 different tests, a CT scan, a transthoracic echo, and a TEE, that are all giving you different answers, to me, that means nobody knows the right answer. So if I was the surgeon on this one, I would say, get me a 3D model printed. And they can oftentimes do that with the data that they've already had from the CT scan. Oftentimes they don't, I mean, I don't know how it is in LA, but sometimes it depends on the hardware. But sometimes if they've acquired the right data with the CT scan, then they can go around and take that data and print a 3D model. And that way you can actually see in your hands, the surgeon can see, Dr. Starnes can see, okay, here's the heart, here's the VSD, here's the pulmonary valve, here's the aortic valve. This is how far away it is. This is where it is, and can determine which one it is. Like, because you in these descriptions, they've used every single term possible: subpulmonary, inlet, outlet. Like that covers the whole gamut. So it really, it's as confusing for me, if it makes you feel any better, as it is for you.
Oh, yeah, thank you. Yeah, that's what we're trying to figure out, and we haven't really got a response from anyone on clarification. I think what you mean by the 3D seems to be probably the next best step.
Yeah, I mean, unless they showed this data like already to Dr. Starnes and he's like, oh no, this is where it is. Like, and I'll tell you that sometimes that happens. I don't mean to sound like surgeons are know-it-alls, but sometimes we see things a little bit different than the cardiologists do, and they'll look at something and say it's this or this or this, and we'll look at something and we'll say, okay, well, I know what this is, and I know how far this is from this, and I know what I'm supposed to do when I open up the heart. So sometimes you can tell without additional imaging or additional testing or additional data. But again, if I was consulted on this as a third party, as a second opinion or something, I would say, get me a model, let me play with it, and then I'll tell you what operation we need to do.
Thank you.
All right. Let me see. Lisa, Andrew, Alex, anybody have any questions? If not, I guess, Tony, I'll go through a few on this list. There's some really good questions here. Anyway, I'll just go through a few of them. One of them comes from an old patient of mine who's, speaking of conduits, whose son is up for a conduit replacement, and remarkably, her son is 14, and I think I put this conduit in when the kid was a baby. So the conduits lasted 13 plus years, which is remarkable, and but also confirms the thing that I've said before, which is you never know with these things. Sometimes they last a year, sometimes they last 13 years, and you wouldn't predict that a conduit placed in a baby would last that long. It shouldn't, but for whatever reason it did. So the question was, is there anything we should be asking, looking out for regarding conduit replacement? Yeah, there are a lot of things. It's too bad this mom wasn't on the call, but hopefully she'll hear the recording. So first of all, ask the experience of the surgeon. And if that's all good, most importantly, ask what type of conduit is planned, how big you think it will be, and how the operation will be done in the sense of will the heart be stopped or not. Under normal circumstances, unless there's an existing hole in the heart, you do not need to stop the heart to replace a conduit. You need to be on the heart-lung machine, but you don't need to stop the heart unless there's a hole in the heart somewhere. Secondly, what type of conduit really matters? So like I answered with the previous question, there's a bunch of different types of conduit, but most of the time in this situation, we're using homographs, which is what I put in this kid when he was a baby. And homograph conduits, which are pieces of an artery with a valve from a cadaver, somebody that's died, can be of different types. The two general types are aortic valve conduits and pulmonary valve conduits. Now, sometimes we use either for either. So for a lot of different reasons, aortic valve conduits are a lot easier to obtain than pulmonary valve conduits, but they're not as good. So typically we had a lot, it was easier in terms of availability to get aortic valve conduits, but I tried to avoid them unless I really had to use them because they wear out a lot faster. So you really want, at this stage, a pulmonary valve conduit. And this child's 14, so he's probably close to adult size. So he should be getting like a, I don't know, 20 to 25 millimeter conduit, certainly nothing lower than like an 18 or 19. And if he is, then that's a problem. If he's getting an aortic valve conduit because that's all that's available, then I'd wait for a pulmonary valve conduit unless it's an emergency. And I can't imagine it's an emergency because you've waited 14 years. So those are the things that are really important to know before your kid goes to the operating room for a conduit replacement. A conduit replacement is one of those things where I hate the word straightforward, but it should be uncomplicated. The only things that can happen usually are bad things, and most of the time those things don't happen. But it's not a very glorious operation in the sense that you're taking a part out and putting another part in. But in that sense, you got to make sure that everything goes right, because everything should go right the vast majority of the time. Okay, that's that. Another question was, where is it? Oh yeah, this was from Jennifer from Manitoba. Is there a recommended time to begin doing physical stress tests? There's a couple of really good reviews about this, but it's a good question. Like, when do I do a stress test on my kid? And really, it's based on indication. Like, generally, just because a kid has heart disease doesn't mean they need regularly scheduled stress tests. They need them to evaluate specific signs or symptoms that are either precipitated by or aggravated by exercise. You need a stress test to identify an abnormal response to exercise in kids with certain types of heart defects. Sometimes stress tests are important to assess the efficacy of certain treatment algorithms that the kid has undergone, either medical or surgical. Sometimes you need a stress test as a screening test for certain like jobs or athletic activities or recreational activities. They won't let you do them because you've got a heart history unless you undergo a stress test that shows, look, listen, I can stress my heart, it's not a problem. And then sometimes they use them just for baseline data if they want to follow something or another. But those are really the reasons for a stress test in a kid. There's no like, okay, my kid has heart disease, so I need routine stress tests. There's a whole bunch of questions about the Fontan circulation, but I don't think, except for Alex, I don't think there's many people in this call that have Fontan kids. And there's a lot of specific Fontan questions that I think probably best responded to when people are here. There was another question about an adult, and they don't know why their right ventricle is enlarged. I think it was, they've had evaluation at the Mayo Clinic and the Methodist in Houston. And just from the one paragraph that was written, I know the answer. So if this person wants to contact me, I can tell you the answer. There was another question about indication for thoracotomy instead of sternotomy for coarctation of the aorta. That's a very good question. Very specific answers. And it's really only if you need to use the heart-lung bypass machine. That should really be the only reason, but you need to know the specifics of the anatomy a little bit better to answer that question. So I'll just leave it at that. And there was another question about narrowing of arteries after an arterial switch. This is from an old patient of mine. And if she's listening or listens to the YouTube video, she can contact me and I can answer that question too. Anyway, I'll leave it at that.
Do you mind if I ask one quick follow-up on the stress test side of things?
Yeah, of
we were recently talking to somebody like in the physiotherapy range about like VO2 max testing, and there was another term around, I'm going to butcher it, spirotography or something. It was like basically the capacity of testing the lungs and understanding like how much output they actually have. Do you have any recommendations on what's actually like helpful or
well, so
relevant
stress testing VO2 max, like we're talking different sides of the same coin here, like that's what that is. So in the athletic world, in the non-heart world, athletes measure their VO2 max, see how conditioned and fit they are. And in the cardiopulmonary world, we measure VO2 max to see how their heart-lung capacity is doing. And spirometry testing is a measure of lung capacities. They're kind of like lung function tests. And so to differentiate heart pathology from lung pathology, which sometimes can be quite difficult in these heart kids that are desaturated, you don't know how much of the desaturation is secondary to their existing heart disease and how much of a desaturation is secondary to potentially some lung disease. And that's why you try to separate the two. Sometimes it's hard to do that, but if somebody's suggesting that to you, that's probably the reason.
Okay.
But VO2
Okay.
max
Awesome. That's
for
helpful.
like in a kid with uncorrected heart disease, well, I'm not a cardiologist, but it would be a bit confusing to interpret. I think it's more important, again, as a trend. Like I said, one of the last things I mentioned was like as a baseline to trend it in the future to see if it's going up, going down, staying the same.
Awesome. Okay. There's one last thing that came in just a moment ago. I just put it into the chat. This was from Mr. Rao. If you want to maybe touch on that one, man.
Do children who treated with the Fontan procedure generally have learning difficulties? No, I wouldn't put that as a blanket statement at all. And like the Fontan procedure, I mean, it partly depends on the pathology. Kids with single ventricles can have lots of problems later on in life that are completely unrelated to their heart. Just like kids with normal hearts can have lots of problems later on in life that are completely unrelated to their normal hearts. So it is true that kids with congenital heart disease tend to have more problems. Some of them related to surgery, some of them not related to surgery, some of them related to other brain problems that they might have, to syndromes that they have. There's a whole variety of reasons. But I wouldn't say that I could ever make a blanket statement that Fontan kids have more learning difficulties. The only thing a Fontan kid is guaranteed to have in terms of limitations is some degree of exercise limitation. That doesn't mean that they can't do exercise. It doesn't mean they can't ski down a ski hill. It doesn't mean that they can't play hockey. It doesn't mean any of that stuff. It means that, you know, they're not going to win a gold medal in the Olympics. That's what it means. So they're not going to be a high performing athlete at an elite level if you only have one ventricle. Like, I think that's unrealistic to think. But as far as, I mean, I can show you so many kids that I've done Fontans on that you could, not just by looking at them, but by talking to them or interacting with them. And these are years later because I'm old now. So like they're in their 20s. And so that you would have no idea that they went through the whole Fontan pathway. And some of them are kids with hypoplastic left heart syndrome that went through like a big operation as a newborn and a second operation and a third operation, and they're completely normal human beings at this point. So other than having half a heart anatomically.
Awesome. Okay, well, I think that about wraps it up. That's all the questions that we have. Definitely thank you everyone for jumping on, submitting the questions. It's super helpful if you share kind of awareness about this with anybody in your networks, at the local facilities that you're at, the doctors you work with, kind of anything else like that. We'll follow up over email probably tomorrow with a link to the video and kind of all that good stuff. And look out for Dr. Gandhi's new website, which will also come in that email tomorrow as well. And that's where you'll be able to sign up for anything in the future that you need to. So
great.
We will wrap it up there.
Okay, have a good night, everybody.
Yeah.